So, профессор говорит, что он хочет рассказать сначала о применении тиогуанина в лечении воспалительных заболеваний кишечника, и эти слайды, они раскрывают проблему в Индии, которая как бы такая же, как и в Украине, то есть отсутствие денег. И сейчас в мире более 2 миллионов людей лечатся тиогуанинами, и если бы они лечились биологической терапией, то это бы стоило гораздо дороже, чем есть сейчас в данный момент.
Okay, so we are using azathioprine and mercaptopurine in the last 40-50 years for IBD. If you look to rheumatology, they use methotrexate, and we know also that methotrexate works very well in Crohn's disease. So the remission rate for thioprines in general for Crohn's disease is up to 70-80%, which is quite a lot. So before dreaming about very sophisticated, expensive drugs, you have to optimize your thioprine treatment or surgery.
Значит, последние 50 лет известно использование меркаптопурина, азотиоприна при лечении воспалительных заболеваний кишечника. Ревматологи часто применяют метотрексат. Эти препараты тоже очень эффективны, мы знаем, при лечении воспалительных заболеваний. И частота ремиссий на лечение тиогуанинами она достигает 70-80%.
Okay, so I work with the thioprine, tioguanine, and I'll give you a little bit explanation about how to optimize thioprine treatment. Next slide. Oh, sorry. Okay, I have disclosures. I'm an advisor for Immusant and HLW for 60G for this for since 2 months. Okay, next.
Раскрытие конфликта интересов.
So if you look to azathioprine, this is azathioprine, it's metabolized in 6-MP and then metabolized in the active ingredient 6-CGN. So it needs a few steps. Then you have tioguanine, that's only one step into the active ingredient. And the side effects based on AZA and 6-MP are based on 6-MMP, 6-MMT, and these sort of drugs give all the side effects in the 50% of the patients. You have to realize 50% of the patients on thioprines stops with it within 2 to 3 years. So I realized in a meeting now almost 17 years ago that there was this drug and it was already on the market. Okay.
Препараты, которые применяются, это азотиоприн, это 6 меркаптопурин, это 6 тиогуанин. Активные метаболиты их, это вещества, которые находятся в сером прямоугольнике, поэтому это все является препаратами, и большинство побочных действий это обусловлено веществами, которые указаны сверху, это 6-ММП, 6-МТМП, и большинство, 60-50% пациентов, которые принимают эти препараты, они бросают это применение в течение 2-3 лет из-за как раз побочного действия, обусловленные этими метаболитами, поэтому еще 17 лет назад профессор утверждал про пользу и про преимущество препарата 6 тиогуанина.
Okay, so this was registered already in 1950 for leukemia and breast cancer because it was so toxic. I come back to that later. Next.
Этот препарат уже зарегистрирован для лечения лейкемии и рака молочной железы.
As we started with this drug, before we moved on to monoclonals in the Netherlands, you see that we started in 2001 with a few patients, and this is a slide of last year. We had 4,000 patients on this drug. At the moment, we have 6,000 IBD patients on this drug in the Netherlands. And we are the only country in Western Europe where monoclonals are stabilizing and the others are growing up.
Значит, первые исследования произошли в 2001 году, до того, как появились моноклональные антитела в широком применении, и вот новый всплеск интереса к этой группе препаратов вот, появился только в последние годы. На данный момент 4-5 тысяч пациентов уже находятся под таким лечением, и Нидерланды являются единственной страной в Европейском Союзе, где применение моноклональных антител, частота применения стабилизировалась, а остальные группы препаратов используются все чаще.
Okay, next. So, our studies were hampered when Marla Dubinsky, in an article in 2003, told the audience that there were severe liver problems. Very short to answer this is nonsense. In the last 15 years, we only found 40 patients with severe NRH, that's the liver disease suggested by her in our country, in users for azathioprine, 6-MP, and Tioguanины, and we published this where did we publish that? In Clinical Gastroenterology 2 months ago.
Да, это публикация данного исследования, который говорит, что побочные эффекты, связанные с тяжелыми поражениями печени, за последние 50 лет зарегистрированы у в принципе, это очень преувеличенные данные о таком побочном действии.
The reason that she probably found it, she was giving to children for 5 to 10 years old a double to triple of what we are giving to adults. So in an adult we give 20 milligrams, she was giving 40 to 60. So she was overdosing. Next. So what is going on? We give this drug in low dosage. We don't start with this drug in daily practice. We start with azathioprine or 6-MP. That's what we're doing. In case we see side effects, we use this drug as escape, or we use, of course, monoclonals in very, very severe cases, but as an exception to start with. Okay, so in the United States they think that I'm very dangerous, but I think at the moment when we have next month our editorial about this in gastroenterology, the Americans will start to accept this. Okay. Next. So with this approach, we can prevent monoclonal use in 60 to 70% of patients. Next. So what's going on? And the research here is performed by you with the mesalazine, very good. I'm a believer that these sort of drugs still work. And you know, this is what we can use. I think this is underused in IBD, and in rheumatoid arthritis, thioprines are underused. Next. So this is what the Americans doing. In simple cases, aminosalicylates, corticosteroids, and then they go on for anti-TNF-alpha. So they don't mention these sort of drugs anymore. And this was a lecture 1.5 years in India. And you know, in India, a lot of poor people, and the majority can't afford this. next. Okay, that was Bruce Sands. Next. So, if you realize the new biologicals, and this is ustekinumab, the authors have major conflict of interest. Next slide. Ustekinumab is almost 4,000 euro per dose, and to bring one patient extra in remission will cost 140,000 euro. So who can afford? Maybe we in the Netherlands can afford, but I would say it's too, you can't do it here. Next. Next. So I think there's too much conflicts of interest at the international congresses. People are driven by the monoclonals for their research. Okay, let's critical look for the biologicals. We are using them in our country since almost 25 years. Next slide. There's one very good study about azathioprine versus infliximab versus the combination. And this suggests that this is not so good, but they didn't do therapeutic drug monitoring, and all patients in this arm who didn't show up were considered failures. The only message which I believe is that the combination of infliximab together with azathioprine is much better. The definition between remission, if patients in this group didn't come to the out clinic, they say it was a failure. If this patient didn't show up, they start to phone them and they came to the clinic. Okay, next. Okay, budget per year, you see major differences. Next. If you look to the thioprines, this is azathioprine, this is 6-mercapto, and this is 6-TG. Miss Allian, who developed this, was so impressed by the toxicity of this that she changed it into pyrinytol and imuran. And she wasn't aware that they were the same end metabolites, okay? And we have started, they were using this in leukemia also 100 to 200 milligrams daily, and we're using this in IBD, let's say, of a patient of 70 kilograms. This one, 20. Mercapto would fit 70 to 100, and this would fit 150. So the pure end metabolites are the same, so by giving this, you give much more side metabolites. Okay, next. This is the lady who did all this work. She got the Nobel Prize for this. Next slide. She got the Nobel Prize. The reason that she shows these dogs here was that azathioprine was used in the first kidney transplant in both dogs. And this was the reason, her work was the reason that we could start with liver transplant, kidney transplants, and all sorts of things in the 60s. She proved it was azathioprine. Next. Okay, so in the United States they do top-down. Next. And the question is for all others, like India, Rust Belt, the Trump voters, and South America, the top-up, maybe. Okay. Okay, so this is the picture as we see it at the moment. This drug is now registered in a few countries in Western Europe for IBD. Next. So until 3 years ago, 6MP was my first choice, and because 60G was not reimbursed by the insurance companies, now things are changing in the Netherlands. Okay, next. Mercaptopurine in daily practice, side effects in 40%, ineffective in 15 to 20%, which is not that good. Next. The major problems are the liver problems caused by the toxic side metabolite, myelotoxicity, also related to 6-MMP, and pancreatitis. Okay, so thiopurine, the efficacy is 60 Gn, the side effects are 6-MMP. Next. Okay. So the toxicity is there, especially when the levels are very high, you see liver problems, and you need a certain efficacy of a level. Okay. A lot of people forget that myelotoxicity is caused by this. They think it's caused by 60 Gn, but this is the problem. So, okay, the message, then you have the ultrametallizers, who have even more side effects because they make much more 6-MMP. Okay, next. You can change that with giving allopurinol, so you decrease azathioprine dosage to 30% of what you are normal doing, and you give 100 milligram of allopurinol, then the 6-MMP is going down, 60 Gn is going up. If you don't have the money for the new thiopurine, this is the way to go. And for instance, in United Kingdom, in England, they have tens of thousands of people on the combination low dosage 6-MP, low dosage of azathioprine plus allopurinol. Okay, next. So that's a magic black box. Next. Allopurinol, you see less side effects, and in general, it's below 10%. And so with this approach, you can optimize your azathioprine 6-MP treatment. Okay, next. So in general, normally, and talking about your patient, 50% of the patients will stop with AZA or 6-MP within 3 to 4 years if you don't optimize with allopurinol. There are more than 10 articles about this. Okay, so we did work, go on with 60G, as the French were saying, lift the resistance in the Netherlands against the monoclonals, okay? Okay, next. So, next, you have seen this one already. So increased monoclonal use in the United States and UK is everywhere. Top-down strategy. Next. So South Africa, which has also a very difficult financial situation. If you invite 2 guests and they tell thiopurines are dangerous and they never work with allopurinol, they're right, but I think they're not very dangerous if you take proper prevention. Then if we're talking about anti-TNF-alpha, you think it's a black box, it works in all, but you have to realize it's not so good after a few years. So still you have to operate a lot of patients. Okay, in monoclonals you have also side effects, primary failure 30 to 40%, secondary failure based on the antibodies also 40%. So be aware when you talk about monoclonals. Next. So I'm a non-believer. I think so much patients are using this, so probably it's not that dangerous. Next. So it is quite common that anti-TNF-alpha also fails. Next. So what they do normally in primary monoclonals is they give, you can't expect if it's a fibrotic stricture that the fibrotic tissue will open on monoclonals. They can't open on thiopurine, they can't open on prednisone, and they don't open on monoclonals. Okay, next. Then you have, of course, all secondary problems, but okay. Next. Okay, so clinical remission without corticosteroids in the study of Colombel after 26 weeks was only 30%. For the infliximab, 45%, and the combination was doing best. But you have to realize, and this is what a lot of people are forgetting, thiopurines worked best after 6 to 8 months. And there are beautiful articles in Elementary Pharmacology that after 8 months, thiopurines are equal to monoclonals. Only the combination is much better. So you have to realize and tell your patients that it takes time to come into remission. Next. So in monoclonals, they start to increase the dosage if it doesn't work, double the dosage, double the money. So this is a major problem. Next. So what we say for azathioprine is a simple slide more than 10 years ago, and that's based on the metabolites. But I don't know, can you measure here in Ukraine the metabolites? And that is... Yeah. I think... Okay, because that's too expensive. So what we can do this in our country for 50 euro. So if you can proper interpretation here of these sorts of things, you can individualize. And the alternative is thousands of monoclonals, €1,000. So I would strongly advise you to discuss it here and that you ask a certain pharmacist to start it. It's easy. We have now in our unit in Amsterdam one lady from South Africa for training pharmacologists to train to start this. And the same, some people from Mumbai will come over also for the same trick. So we measured this already 2 weeks after starting thioprines in all of them. Okay, next. So thioprines for everyone. What are we doing? We are non-believers of the genetic measurement. Much more expensive. Doesn't predict very good. Therapeutic drug monitoring, that's what we do. You see, I gave this lecture also in London 1 month ago, okay. But okay, there's only one country where people can't start monoclonals if they have not proven with therapeutic drug monitoring that the thioprines are properly dosed. Okay. Next. So, what are we doing? You can also say already, we start TO6 at the moment in the Netherlands when patients have problems. However, we see now that the growth of the TO6 is going up and up because a lot of IBDologists in the country, they say, we don't start azathioprine anymore. So that is, they're taking advantage, and we say the registration is only as escape drug. Lanfis is probably available here by the internet. TO6, the raw material is produced by Grindex in Letland, and Urso is coming from Letland to you guys, so probably you have access to this. Next. Okay, we look to the liver. I explained to you already. Side effects are very, very low of these sort of drugs. So how we see it at the moment is azathioprine is good for 50% of the patients. 6-MP has much less side effects, but if we look to TO6, 80% of the patients do quite well. after azathioprine and 6-MP. So if you start directly, you have a success rate of not that you bring them all in remission, but the compliance for this after 5 years is more than 95%, which is extremely high. Okay, so the dosages are a little bit different as it is more pure substance. Next. Next. It works, and this is also interesting. We could only publish this in the World Journal. Not in Gut, not in Gastro, not in leading journals. All of the editorial boards did send it to us and told us, nobody is using thiopurines anymore. We're not interested. And that is now what I'm talking to you about an editorial in Gastro is not that we can stop this sort of thinking, but we start the discussion again. Next. So, simple message, it works. Next. We also use it in autoimmune hepatitis. We published this in APT last month of the first 50 patients. And we have now started a randomized trial, azathioprine versus 6-TG in autoimmune hepatitis in UK, Belgium, and the Netherlands. And of course, we must do a clash of the thiopurines, as we say. So azathioprine in all new patients versus 6-TG. And this trial will start for Crohn's disease in London in a few months, led by Ansari and Sanderson. And in India, the clash will start for ulcerative colitis in a group from Delhi, Mumbai, Bangalore, and Vellore. So, simple message, we can't stop this anymore. This is what's going on in the Netherlands. We expect that the number of 6-TG users will be 20,000 in 2 years from now. That's my message. Okay, so I hope I gave you in this simple, according to the simple patient we had, that's a patient of 3 centimeter. I would start thiopurines. That's the message. Okay, thank you. I hope you have questions, because some people say I tell fairy tales. Okay. I hope so.
Well, thank you very much for the presentation. My question is, if you don't have ability, of course in Netherlands it's not possible, but if you can't measure the metabolism of drugs, what do you recommend for clinical practice? Because in Ukraine, we don't have opportunity to do it.
Very difficult question, of course. Yeah, of course. Yeah. Then we were looking for the mean volume of the erythrocytes. If they were going up, then we say it worked. we looked, of course, much better to the leukocytes if they were going down. So in the first 8 weeks in azathioprine, you have to look very good to thrombocytes, leukocytes, and second endpoint is also your calprotectin. If it's going down, you can say something is working. But indeed, it's very difficult, and it's only €50.
Yeah, but
yeah.
we are now about...
Well, I would say you can make a fortune if you do it in private. You start to measure it somewhere. You have to do it.
It's important,
yeah.
Especially if you compare the price for monoclonal and the price for the TF. Because now, personally, I use azathioprine
yes,
for this kind
of course.
population. And sometimes it's unique possibility for this group of people because we don't have a reimbursement for the monoclonal.
Of course, yeah. No, we are, for instance, this TO6 now is per day in the Netherlands €4. That's a lot, but it has to do that for registries, 50% of the price is going to that registry. We think that the price of TO6, and we talked last week with a firm, I don't know if you know that firm, Ranbaxy. Ranbaxy is a very major firm in India, and Ranbaxy wants to produce TG now for the Indian market. And we think that the price in India will be 40, 50 euro cents per day. And that is fantastic. So, and the other thing is, the Crindex is manufacturing probably the best quality in the world of this drug. However, they're reluctant to export this to the so-called former Soviet Union countries based on the registration rules. But I think that's ridiculous. I think they have to think of a compassionate use program, and you have to ask those representatives, can we have access that you buy the raw material for a low price and capsulate it yourself for 20 milligrams? Because it's good. I started this, it was my idea, but people are thinking I'm becoming rich because of this. So far, I never earned money for this idea. So some people say, you're quite stupid that you didn't do it. I say, well, it might be, but okay, my dream is to give proper treatment to patients. And my money is good enough. I'm not complaining about my money. But okay, I would say for the moment, if you do azathioprine, if you see the side effects of the liver, go down with the dosage to 25%, give allopurinol. It's also easy. Yeah? Other questions?
Experience of the decreased toxicity of Tioguanine with allopurinol as was for the
Yeah, you have to look to Ansari. Ansari is his name. That is articles in Gut, leading articles. It's a guy from London. So you have to look for azathioprine and allopurinol and you find the articles. And it works, it's easy. Then you see also how you have to do it in daily practice. Yes, for sure. Yeah, for sure. So Mercapto is because Mercapto, if you look to the side metabolites, because it's later, it's easier side metabolites to do with allopurinol. So some people in the UK, if they see little liver abnormalities, they stop azathioprine, start a dosage of 50 or 25 milligram of Mercapto purine with allopurinol. Mercapto purine is more expensive, but if you give a very low dosage, in combination with a very cheap drug like allopurinol, you're even probably lower in price. For you, if you don't have access to the pure substance, as Grindex is not willing to give it to you, then it is. Otherwise, I hope Ranbaxy will start to produce after quality measurements, because the trick, then I hope they will start in May, June next year, and probably they start to export. Yes?
Aren't you afraid about the killers from the monoclonal mafia?
Oh yeah, the monoclonal mafiosi hate me. Is that the simple message? For instance, I'm invited in New York in Columbell's unit, in Chicago Hanauer's unit, but I never ever I never got an invitation of ECHO, never. I'm very dangerous guy, you know. No. Okay. Thank you.